Thank you everyone. For the next segment of today's lineup, that is a guest lecture on pre-leukemic conditions, I am pleased to welcome Dr. Ganaka Senaratne and Dr. Kirti Kularatne. Over to you, sir.
I'm Dr. Kularatne. My co-chair is Dr. Ganaka Senaratne. We'll be moving to a guest lecture on pre-leukemic conditions by Dr. Mithun Shah. Dr. Mithun Shah is a consultant hematologist from Mayo Clinic, Rochester. Over to you, Dr. Mithun Shah.
Good afternoon, everybody. My name is Mithun Shah. I'm a hematologist and a transplant physician at Mayo Clinic, Rochester. And I am going to talk a little bit about the pre-leukemic conditions for the next 20 minutes or so. So before I jump into the actual discussion, this is a stimulated dialogue, if you will, with a patient of mine. This is, I do in part pre-leukemic clinic at Mayo Clinic. So this is something goes on with our patient here. So 62-year-old former smoker who feels like he's in the best condition of his life, feeling well. Incidental testing shows some mild macrocytosis, and you being a very thorough physician, you ended up getting multiple tests that cost him pretty dearly. Now he's back with all the workup done, and then he's asking you these questions because you have found what they call clonal hematopoiesis or clonal hematopoiesis of indeterminate potential, or CHIP. So patient is very curious about this, and he's asking you these questions. Do I have leukemia or cancer? And you go, no, not really, but you are at risk of developing leukemia in future. Somewhere between 3 to 20-fold of higher risk of leukemia. So that, of course, gets the patient worried. So anything else that I should be worried about? Yes, you are at risk of developing stroke, heart attack, severe COPD, death from severe COPD, risk of COVID, some multiple infections are high. So, of course, the patient is now not as excited as they were a few minutes ago. And they're going to say, well, do I have any treatments? The answer is yes. Would you recommend any? No. And here is where the patient goes from excited to curious to rather bewildered. And so this is something that actually somebody told me, you would really want me to get sick before you start treating me. Is that right? And that actually had me give a pause. And the answer was yes, because there is nothing that we have known, proven that we could do to help this patient, and which is what leads me to the next a few minutes of discussion. Sitting here, knowing, I'm originally from India, so knowing that the chronic health diseases are a huge part of it, the focus on pre-leukemic condition feels a little far-fetched to worry about. But something that I want to emphasize here is that the leukemias, and I just use AML as a potential example here, acute myeloid leukemia as a potential example. This is really a very deceiving picture, because there is a lot more that happens in the background, and I'm hoping to convince you by the end of this talk that even as an internist who doesn't have access to very fancy testing and very fancy treatments, this is something that you will be seeing much more frequently than you think we do. Before I jump into the rest of the presentation, I wanted to just go back to medical school 101, if you will. Bone marrow gets divided, the common hematopoietic stem cells gets divided into committed lymphoid or myeloid progenitor. The lymphoid progenitors will give rise to B, T, and NK cells and plasma cells. So this is what CLL and myeloma live in, and some lymphomas around the same arises from this section. On the myeloid side, all the myeloid leukemia, the MDS, MPN, acute myeloid leukemia originates from the common myeloid progenitor. So the question is, do we know about any precursor diseases in this setup? And we do. There are myeloid precursor leukemias that are associated with MDS, MPN, and AML. On the other hand, there are lymphoid CHIP associated with CLLs, lymphomas, and multiple myeloma. So pretty much any leukemia that you are likely to see there is and could have been a precursor disease that we missed for years and years. So with that, I'll start with what they call MUGUS, or MGUS, monoclonal gammopathy of undetermined significance. You will see throughout my discussion, hematologists have love for four-letter words, and they keep coining new and new of these, and it becomes really difficult to keep up with this. But this is actually a very old concept. This was actually pioneered at Mayo Clinic back in 1990s, early 80s and 90s. And what it is that if you read this slide backwards, you have multiple myeloma, which is a leukemia of plasma cells. And it is associated with a very defined protein pattern. This is the protein pattern. I'll just give it to you right now. But then there are a lot more patients who have these protein pattern, but they do not meet the criteria of myeloma. So you have diagnosed this person has a monoclonal protein. There is a monoclonal plasma cell in the background, but they don't meet the myeloma criteria. So what are you going to call these patients? So not the actual part of the discussion, but smoldering multiple myeloma is an entity. There are some patients who don't even meet that criteria. So what are you going to call them? And they are called monoclonal gammopathy of undeterminate significance, meaning we don't know what to make out of that. This is the actual definition if you are interested in, but you have to know that you cannot have any end organ damage that defines myeloma, meaning this is truly what they call undetermined, and we don't know. The patient has monoclonal gammopathy, but we don't know any damage that it has caused. Now, to the initial point I had made, why do I care? The point is because if you are and if you go out on the Golf Face Road and interview 100 people, look at their ages here, 60 to 90, about 8% of them will have monoclonal gammopathy. Even in US, even at Mayo Clinic, where this is people's daily work, only 2% of them have been diagnosed, meaning there is this huge difference that people are walking around with this monoclonal gammopathy that you and I don't know about. They haven't been clinically detected. It's more likely in male than female. And if somebody had multiple myeloma, their first and second degree relatives are more likely to have monoclonal gammopathy. Let me see. And well, so as you would imagine, if you have monoclonal gammopathy, you can develop a myeloma, but actually that's a very small proportion of patients here. Complicated graph, but basically most people die without developing myeloma. Most people actually, very few people, 1 to 2% will develop myeloma as they go forward. So then why do I really need to know about this? Because this is a very nice review from two of my colleagues. And this is actually known associations of MGUS. Remember, we're thinking this is undeterminate significance. And here is a long list of things that we know are associated with MUGUS. So you have a patient with Schizner syndrome or Neilman myopathy, or even a corneal copper deposition. There is a small chance that at the bottom of this is an abnormal protein that came out of abnormal plasma cell. That is what is contributing to this problem. A lot of people with neuropathy are walking around with neuropathy not knowing that the neuropathy actually came out of plasma cell, and treating that plasma cell clone may actually help them. To make my point, I used another colleague of mine who has done some phenomenal work recently, got a lot of press in the US. They have I wish they came up with a better name, but they call it monoclonal gammopathy of thrombotic thrombocytopenic significance, meaning somebody had a monoclonal clone, M protein, diagnosed here in blue, and this is their platelet count that actually got corresponded. And turns out when they did the very, very well-performed study, they actually showed that the monoclonal protein was anti-platelet factor 4 protein, which is associated with what they call heparin-induced thrombocytopenia, or HIT. The point I'm trying to make is 6 months ago, we would have never known to make the connection between a plasma clone and HIT. And now we know that this is a known association, and treatment would be entirely different. With that, I'll move on to another pre-leukemic entity called monoclonal B lymphocytosis, or MBL. This is a precursor for another leukemia, the most common leukemia in the Western world, called chronic lymphocytic leukemia, or CLL. Now, same concept as before. You need about 5,000 clonal cells for somebody to be called CLL. The technology has gotten to a point we can identify 6, 10, 15 clonal cells. So what happens when somebody has clonal cells but they don't meet the criteria? That's called, meaning the threshold is 5,000. If you have less than 5,000, you don't have bone marrow dysfunction, you don't have lymph nodes, you would be diagnosed with what they call MBL. Again, why do I need to know about that? Because this is a relatively simulated work, but if you see, this is the lymphocytes on the bottom. Oh, you don't see what I'm seeing here, huh? Okay. This is the number of lymphocytes, and this is the percentage of cases. You see that when you get to this gray is when you know as a hematologist that this person had CLL or precursor CLL. Whereas most people in the dotted line actually have monoclonal cells long before that. Some people as little as 1,000 or 100 or less. So if you just use this criteria, going back to the HLH discussion, if you just use the HLH criteria, you are going to miss a lot of patients. Similarly, if you only use the 5,000 cutoff, you are going to miss pretty much all of these patients that you would have missed. Now, you may ask me, why do I need to know about this? Again, having MBL puts you at about 7-fold higher risk of developing CLL in future. So as somebody who has an elderly parent, I would rather know this 10, 15 years ahead of time rather than at the time of diagnosis. But more importantly, So more importantly, just having an MBL, no CLL, you don't have a leukemia that we know of, puts you at about a 1.5-fold higher risk of developing a serious infection that gets you to the hospital, 7-fold higher risk of other lymphoid malignancies, and about 2-fold higher risk of developing melanoma of all the cancers and some other solid cancers. So people with MBL who develop these complications actually don't live as long and they die sooner. So it's not that that it's the CLL that is the problem here. It's the inherent bone marrow dysfunction or stem cell dysfunction that causes these patients to die. Now I'll get to what they call clonal hematopoiesis. I initially introduced the term, and I'll go into the detail of this. And just a little bit of a background. You and I, most of us, have somewhere between 50,000 to 250,000 stem cells. We were born with it. And they actually stay pretty stable for 60 years or so of your life. And then the number of stem cells dramatically drop. That's just nature. What happens though, then after that, about 20% of clones will disproportionately account for about 60% of hematopoiesis. However, if you have an outsized, so one clone, one stem cell is now providing 30% of your hematopoiesis. 30% of blood cells are coming from one little stem cell, and that is called clonal hematopoiesis of indeterminate potential. And how common is it? This is a very elegant study, a bunch of studies actually done about 10 years ago now. If about 3% of 40 years old, so some of us sitting here have CHIP. If that age goes up to 70, this goes up to about 15%. So again, going out to the community and sampling 100 people, 15 of them will have the CHIP. That number goes up to about 1 in 3 when you go up to 80. As we are all aging, there is a good chance that your patient, 1/3 of your patients harbor a clone that we didn't know about. Now, somebody also mentioned NGS before today. Once that NGS becomes widely available in India or Sri Lanka or in your community, your people are going to get this NGS testing. And once they start getting NGS testing, about somewhere between 10 to 30% will come back with a result and say, well, what does this mean for me? Increased risk of clonal hematopoiesis with age, smoking, previous cytotoxic treatment, and for some reason we can't explain with early menopause in women. Oh, sorry. I'll skip this, but I just want you to know that there is a difference between CHIP and CICUS. Again, a lot of 4-letter words here. CHIP is when you have normal hematopoiesis. CICUS is when the hematopoiesis is starting to be detrimented. This is one of my favorite slides. All these 4-letter words. Again, I don't expect you to know all of these, but these are really used in everyday clinic now for us. Somebody has a clone, whether they have cytopenia, whether they have dysplasia, meaning abnormal counts, or there is a selection pressure, and what is the malignant potential. These are all starting to be, they are a hazy bunch of entities, but they are starting to be defined more elegantly. So I spoke to you about some other leukemias, MUGUS and MBL, but there are some other genes, I won't go into the details of it, which put you at a higher risk of lymphoma than the blue bar, and at a higher risk of myeloid leukemias, MDS, MPNs, and AMLs. And those are now starting to be defined as well. So somebody with that mutation, you can counsel them and say, in the next 10 years, there is 30% chance that you might develop a lymphoma. Let's start planning on this. Not everybody with a clone will get leukemia. Life is not that simple. People can have clone that they will die with that clone. That clone did not do anything particularly bad that we know of. So there are some risk calculators, and I really don't expect us to go into that right now, but there are some risk calculators that people have used. And based on that, you either have almost no risk of developing a leukemia or some intermediate risk. But if you are on this red bar, there is good 40% chance of you developing a leukemia, 40 to 50% chance over the next 10 years. And again, this is being evaluated further, but personally, I would like to know if I fall on this curve versus this curve, and whether I need to be more worried about my risks. This is probably more interesting for the internal medicine audience. Okay, I have a clonal hematopoiesis. I have a mutation in a gene called DNMT3A. Okay, all alphabet soup. What does it mean for me? What it really means for the patient is that there is about 12-fold higher risk of coronary artery disease just by having a mutation in a gene that we didn't know about. So you can do a testing and you find that mutation, you can tell your patient that you are about 12-fold higher risk of developing a coronary artery disease. You are at higher risk of developing MI, you are at higher risk of developing systolic as well as diastolic heart failure. Similarly, smaller association, but if you had mutation in a gene called TET2, you are at about twofold higher risk of developing stroke, whether it's a hemorrhagic or ischemic stroke. But it's not, again, it's not true for every single gene. For example, DNMT3A or JAK2 or TP53. It doesn't matter whether you have that clone or not. But if you have the TET2 clone, which is one of the most common clones we find, your risk is about twofold high. So us knowing more about it will actually help us guide and prevent, participate in preventive medicine. So this is my way of visualizing what do I really need to think of when I see a patient with CHIP. CHIP patients, everything else being equal, just having that clone puts you at a higher risk of death, higher risk of cardiovascular death, higher risk of cerebrovascular death, higher risk of dying from COVID-19. And these are all independent associations, not just associations. C. diff, strep, HIV, COPD. But as a silver lining, people went and looked for it and said, well, how about Alzheimer's? They must be at a higher risk of Alzheimer's. Turns out there is a reduced risk of Alzheimer's disease. Again, we don't know why, but this is the concept, this is the take home I'm hoping you will take, that the clonal hematopoiesis somehow, we are not sure exactly, it feeds into the inflammation. Inflammation propagates the clone, pre-existing clone. So this is a circle that we are getting into until a patient has an event. We know that it happens through pathways of interleukin-1, causes atherosclerosis, through NETs, and through thrombosis. We just had a new paper come out that shows about 36-fold higher risk of thrombosis by having a mutation in a gene called JAK2. So this is our current limitation. So I told you all about what we know. What do we not know? First of all, this is not a disease. This is an entity. Going back to my patient, I would tell them, I don't know what to call your pre-leukemia. What is the right threshold is not known. The more sensitive technique you use, the more people will have clones. In fact, there are studies done that show that with a very detailed techniques, 100% of even cord bloods, kids before they are born will have some kind of clone, and we don't know whether that means anything to them or not. So this is my last slide. My take-home messages. Pre-leukemic conditions are way more common than you and I like to think. They are risk for subsequent hematological malignancies. The risk itself is fairly small, 1 to 2%, but higher than what you would see otherwise. It's not a disease, but it is associated with increased morbidity and mortality. MUGUS with all the multi-system disorders, MBL with immunosuppression, and clonal hematopoiesis with inflammation. So thank you very much for your time.
Thank you so much, Dr. Shah, for that interesting lecture on pre-leukemic condition. Because of the interest of time, we might not be able to entertain any questions. We would like to thank Dr. Shah for his excellent lecture on behalf of the Sri Lanka College of Internal Medicine. May I invite Dr. Kirti Kularatne to hand over the certificate of appreciation.